Good morning from a not-so-sunny Edinburgh. My name's Dr. Rachel Sutherland. I'm here on behalf of the Royal College of Physicians, Trainees and Members Committee. And with me, I've got Professor Mark Strachan, who is a consultant diabetologist and endocrinologist here at the Western General. Good morning.
Hello, Rachel. Morning, everybody.
As you may remember, Prof Strachan was the first in our illustrious Hall of Fame of recording podcasts at the RCPE. And we talked initially about COVID and the impact of diabetes or diabetic patients in the COVID context. And we've had a few requests for a follow-up podcast from Prof, which he has very kindly agreed to. And we thought that the most appropriate thing to talk about today would be about how to manage the hyperglycemic patient within the acute care setting. And so I'm just grateful for Prof to outline a little bit. We'll start by just talking a bit about the patient set who come in hyperglycemic to the acute medical receiving unit. So Prof, with that preamble in mind, I just want you to talk through how you would approach and think about people who are hyperglycemic who walk through the door of our medical admissions.
Yeah, well, as you know, Rachel, I suppose a high blood sugar level is one of the commonest blood test abnormalities that we see in people coming in through the front door of our hospitals who are acutely unwell. And you can divide the causes of that high blood sugar into 4 different categories. So most commonly, these will be people who have a known diagnosis of diabetes, and as a consequence of their acute illness, their sugar levels are running perhaps higher than normal. The second category would be people who have pre-existing diabetes, but it's just not been diagnosed. And those individuals, of course, can be identified if a hemoglobin A1C is checked at the front door, because it will, by definition, be elevated. So you've got essentially 2 categories of people with diabetes, those where it's known and those where it's not known. The other 2 categories occur in people who do not have a prior diagnosis of diabetes or who don't have pre-existing diabetes. And the first of those is what we call stress hyperglycemia. So in essence, the severity of the acute illness causes a huge outpouring of hormones like adrenaline, cortisol, that antagonize the action of insulin, make us more insulin resistant, and as a consequence, blood sugar levels rise. But once you're over the acute illness, once that hormonal outpouring, once the inflammatory mediators have all settled, then the sugar levels go back to normal. And that is true stress hyperglycemia. The 4th category would be where there has been an acute precipitant of the diabetes. Now, if I had been giving this talk 18 months ago, I'd have said, well, really, the only important cause of that would be steroid therapy. So people who have been given high doses of glucocorticoids for whatever reason, and in susceptible individuals, so usually older people and people who are overweight, somebody who you might think might in the future get type 2 diabetes, that steroid therapy is enough to tip you over the edge into the diabetic range. But of course, in this COVID era, one of the things that there is a suggestion around is that as well as causing stress hyperglycemia by means of the severity of the acute illness, COVID might actually induce diabetes. So there's evidence that the COVID infection can directly affect the beta cells in the pancreas and impair insulin secretion and actually precipitate diabetes. So, as I say, there are 4 reasons why somebody may have high sugar levels coming into hospital. They've either got diabetes and we know it, they've got diabetes and we don't know it, stress hyperglycemia, and an acute precipitant of diabetes.
I think that's a really helpful way to sort of compartmentalise how you approach it, because understanding how you can categorize people can perhaps target your the way that you would investigate things. I've just got one question about the third category you talked about, the stress hyperglycemia. Does it mean that you need to follow these people up further down the line once they recover from, their UTI, or, I'm thinking about a lot of the people I see have quite a severe pyelonephritis, and they'll have an initial sugar that's a bit raised, and then it also seems to melt away.
Yeah.
Does it predict, in the future that they might be more likely to develop a formal diagnosis of diabetes?
Yes, you're absolutely spot on. So stress hyperglycemia is a bit like steroid-induced diabetes in that it tends to occur most commonly in people who are susceptible to get type 2 diabetes in later life. Older people, more overweight people. That's not an absolute, but broadly speaking. So just as a rough example, if you come into hospital with a blood sugar of over 15, and it is true stress hyperglycemia, so all goes away after you're well, over the next 5 years, you are 15 times more likely to get type 2 diabetes, to develop type 2 diabetes. So yes, stress hyperglycemia is a harbinger of your enhanced susceptibility to type 2 diabetes in the future. It is also associated with, if you come in again with a sugar level over 15 to hospital, you are 2.5 times more likely to die over the next 5 years. This is separate from the severity of the acute illness. You have a higher mortality in the following years. So yes, people who have true stress hyperglycemia should be followed up usually in primary care with an annual check of either fasting glucose or an HbA1c, because they are at increased risk.
I think that's a really important point for me, because it's something I don't necessarily make sure are in my immediate discharge letters to the primary care teams. So I think that's an important thing that will actually change my practice going forward from here, because as the patient gets better, their hyperglycemia tends to resolve, and then it's resolved by the time you're discharging the patient. But so to comment and make sure that the primary care physician's aware of that initial episode so they can do this follow-up is probably incredibly important.
And the other thing I would agree completely with that, and you're not alone in that, because of course the thing as well is, we're handing on patients the organizational memory of that sugar of 15 when they first came in is not high. If you've been in hospital for 2 or 3 weeks, people do forget about that. But the other thing I would just emphasize is that if somebody does come in with a very high sugar and they're not known to have a diagnosis of diabetes, do just do a hemoglobin A1c add-on to just resolve the question of, is this pre-existing diabetes that's undiagnosed, or is it going to be stress hyperglycemia?
And they're not as expensive as they used to be, the HbA1c as a test, are they?
Well, I mean, an HbA1c test costs, I think it's between £7 and £10. If you put that in the context of the cost of 1 day in hospital, it's trivial. So,
and probably very helpful for our primary care colleagues further down the line as well. It's that actually a helpful thing to get done.
Exactly.
That's been really informative. Thank you. So I think I probably need to frame and just step back and say, what would you count as normal? And when you have somebody that comes in with a high sugar, where would your aims be? What are the numbers that you use to couch this?
Yeah. So, well, the standard advice within the NHS in Scotland is that for inpatients, sugar levels should be maintained between 6 and 12. That's for inpatients with diabetes. And in terms of stress hyperglycemia, if that's what the individual has, I think also that figure holds true as well. We know that hyperglycemia is bad for you in an acute setting. So there are many studies that have shown that, I mentioned the longer term mortality of stress hyperglycemia, but in terms of acute morbidity and mortality, if sugar levels are higher, that increases your length of stay, it increases your inpatient mortality. It increases, for example, in surgical patients, the risk of post-operative infections. It's just not a good thing. Now, why is that? Well, the etiology of hyperglycemia in acute illness is complex, so it's no surprising that the explanation of why it's bad for you is complex. But broadly speaking, if you're hyperglycemic, we know that causes an osmotic diuresis. You lose electrolytes. That's not good. You will have a relative degree of volume depletion that makes your blood more hypercoagulable. So again, that's probably not going to be good. And we know that hyperglycemia does affect the function of the immune system, and so that enhances your susceptibility to infection. So acute hyperglycemia is not a good physiological state to be in. And so intuitively, we want to get those sugar levels down to as normal a level as possible.
I can remember as a younger doctor having a number of regimes. I think one was called Dagami.
Dagami, yeah. Oh. See, Dagami, that brings me back. So yeah, the Dagami study. So that is an old study now. So in fact, I can't believe you can even remember that. That is so. So Dagami was actually published in 1995.
Gosh, I'm old.
That was, at the time, it seemed like a real landmark trial. So that this was a trial in people coming into hospital with acute myocardial infarction, and they were randomized to conventional blood glucose control, which at that time was really not doing very much at all, versus an intensive regime which included IV insulin and then subcutaneous insulin for 3 months. I should have said that these were people coming in with an acute MI who were very hyperglycemic. And in fact, from memory actually, the average glucose for the participants in Dagami was about 15 on admission.
Right.
So these were very hyperglycemic patients. And the results of that trial were astonishing, because what they showed was that mortality was reduced by a third by this intervention. And so that then, as you've hinted, led to all of this effort to try and get sugar levels down, and people were putting IV in. But one of the problems with the design of Dagami was that we didn't know, was it the IV insulin that was the important thing? Was it the subcutaneous insulin on discharge? Was it both? So they did another trial called the Dagami 2 trial, where basically people were randomized to have IV insulin only, or IV insulin and subcutaneous insulin, or standard care. Now in that trial, the average sugar going into the trial was lower.
Okay.
I don't know whether just diabetic control was better at that point in time or whatever, I don't know. But anyway, it was better. The headline result of that trial was there was no difference, that the acute intervention made no difference to long-term mortality. And at the time, everybody was just sort of, how can that be? You know, how could the results of the original Dagami trial have been so positive, and yet the results of the Dagami 2 were so, unimpressive? And people were saying, oh, it was just, it was just underpowered and whatever. But actually, so that there's two things just to remember about that. In terms of the original Dagami trial, it's a trial actually now, despite it having been so important at the time, that is actually almost irrelevant to modern practice, certainly in high resource countries, because these were people coming in with full-blown acute myocardial infarctions, ST elevation, rise in CK. Virtually nobody going into the trial was on a statin. Virtually nobody was on an ACE inhibitor. More than half the participants in the trial were thrombolized.
Gosh.
And nobody got PCI.
Okay.
So it does not, the patient population in Dagami does not reflect in any way what we see today in terms of acute myocardial infarction, acute coronary syndrome. So that's one thing we have to bear in mind. The second thing is, if you actually look at the Dagami 2 graphs, the headline was there was no difference between the 2 acute interventions and standard care. Actually, if you look at the graphs, although it wasn't statistically significant, mortality was higher in the acute intervention arm.
Gosh.
Now, everybody ignored that at the time. They said, "Oh, no, that doesn't. It wasn't statistically significant." Was the thing. But the glucose targets that they were aiming for in DIGAMI 2 were tighter, and say people had lower sugars going into the trial. And going forward, there have since been a plethora of studies looking at acute management of hyperglycemia in hospital and looking at mortality outcomes. Now, the best of those is what was called the NICE sugar trial, which was an intensive care study, multi-center intensive care study. In that trial, they were aiming for super aggressive glycemic control in people in intensive care. They were aiming for target sugars of about 6.
Gosh.
I mean, really, really, really tight. But it was an intensive care setting.
Yeah.
They were able to do the monitoring and everything. What did NICE sugars show? It showed that if you compared the outcomes in people with intensive versus standard glucose control, that the outcomes, the mortality was worse in the intensive arm. So
that's a bit counterintuitive, isn't it?
Totally counterintuitive. And that held true if you looked at surgical ICU patients, medical patients, if you looked at people with pre-existing diabetes, people without pre-existing diabetes. It held true. If you went for super aggressive control, you ended up with worse outcomes at the end of the day. There was another trial called the Biomarks trial, which was a trial looking at people with acute coronary syndrome, and they were looking to see they used troponin as a marker of infarct size, and they were looking to see did intensive insulin treatment reduce infarct size. It didn't. But again, what did they find? Statistically, overall, there was no difference in mortality. But in the Biomarks trial, nobody died in the conventional arm. 5 people died in the insulin intervention arm, and they died of hypoglycemia.
Oh gosh.
And if you look at the NICE sugar data, hypoglycemia, even in an intensive care setting where you've got bloods being done all the time, hypoglycemia was much more common in the intensive arm than in the standard arm. So my personal belief is that the reason that we don't yet see benefit of very intensive control inpatient studies is because the improvement in hyperglycemia brings with it a significant increase in the risk of hypoglycemia.
And so in a way, you're overriding your own natural physiological response. So the stress response we talked about, it is a physiological response.
Yeah, well,
insults.
Yeah, absolutely. Well, I said that all these stress hormones make you go hyperglycemic, but in turn, if hypoglycemia is a very, very, very substantial physiological stress for an individual. Again, you pour out adrenaline and cortisol and other counter-regulatory hormones, heart rate shoots up. It is a significant physiological stress. So again, to me, it is not, it is biologically plausible that for particularly frail, older people in hospital who are unwell, that if they become hypoglycemic in hospital, that will have a very adverse effect on their outcomes. And again, there are observational data that show people who have episodes of hypoglycemia as an inpatient have longer stays in hospital and have increased mortality. So these are, hypoglycemia is bad. And the problem is that we just, the standard variable rate insulin infusion that we use on hospital wards to manage hyperglycemia is a very, very powerful tool. It works too well. And of course, on a busy medical ward, it's difficult to be monitoring sugar frequently enough. We need to be, in order to make a variable rate insulin infusion safe, you have to be monitoring glucose continuously. Doing, a finger prick test once an hour is
It's a
ultimately
snapshot.
it's a snapshot. It's not enough. It's a single note in a long piece of music.
Yeah.
And that's the problem. And of course, we all know that, again, on busy medical wards, that even if you're doing it hourly, that's pretty good, but it doesn't always happen hourly.
Yeah.
And so you can see why that, although it's desirable, you think, look, I'm being a really good doctor, I'm getting this person's sugar levels down to 5 or 6 millimoles per litre. This is really good. But actually, it's not beneficial for the patient, because all you're doing is increasing the risk of hypoglycemia and physiological harm. So that's why I think the 6 to 12 target is actually pragmatically a very sensible target that we're aiming for.
In sort of summary, it's like anything in life. The extremes are absolutely the things to avoid.
Yes,
so you neither want it too high nor too low, and hence this 6 to 12 is a happy middle ground that enables the patient to go through that acute phase of illness, and you support making sure they're not tripping into the 20s, late teens, but also you're not putting them at significant risk of hypos. I think that's a really good couple of numbers to have in your head of where you're aiming for it. Because I know as a junior doctor, from F2 sort of registrars, and the nurses can often get very twitchy, and you can get phone calls about this, that they're keeping up, and you're giving these constant sort of minimum correction doses, and it's almost like a false sliding scale and actually, just keeping those numbers in your head can probably keep the patient at a safer index. That's really helpful. Again, something that is good for me to have in my head, and will probably change the way I approach these things. And I just dread to think of all those poor people that were put on my Dagami regime all those years ago. And another thing that I wanted to pick on, you talked about this, especially for frail older people, because I think that there is something that changes in your physiology, particularly as you get older or as you accrue multiple chronic diseases. So I have a subspecialty training in stroke medicine, and we know that, older, more fragile brains that are more vulnerable to insult, and it completely makes sense. And I know that we've tried in stroke as well, close glycemic control, and again, it was something that didn't show benefit.
It showed no benefit at all.
And it makes sense in the way that you describe it, actually, that the brains are very vulnerable during those periods. So I think that's really helpful to have that as a caveat in your mind and keep the 6 to 12. So are there any technologies that might be able to, in the future, help us with this? Because I know there's lots of loop chat and loop communities that are happening. So for the people who aren't familiar with that, would you just explain a little bit about that?
Yeah, well, diabetes management, type 1 diabetes management, is increasingly becoming a technological disorder. So you'll all have seen more and more people with type 1 diabetes coming into hospital with insulin pumps, and you'll have seen more and more people coming into hospital with continuous glucose monitors, such as the Freestyle Libre device. And we now have systems that are available where the continuous glucose monitor talks to the insulin pump, and the pump in effect makes many of the decisions around the dosing of insulin. So for example, if the sensor predicts that the person is going to go hypoglycemic, so you're not even hypoglycemic, it predicts that you're going to go hypoglycemic, then the pump will switch off and it will start up again as the blood sugar levels start to rise. And going forward, this of course is in terms of day-to-day outpatient management. Going forward, the future of type 1 diabetes, I have absolutely no doubt, is we want the vast majority of people with type 1 diabetes to be on what we call sensor augmented pump therapy, what's called a closed loop system. So basically you take the human element out of the decision making around insulin, and it's all controlled electronically with algorithms based on the continuous glucose monitoring data. So that's what's going to happen over the next few years, finance permitting, in type 1 diabetes in a sort of general community setting. However, you can see that technology could very easily transfer itself to an inpatient setting. You know, I've spoken of the problem of the hourly BM that's done, or the not so hourly BM, or even if you are doing an hourly BM, that's still not being frequent enough. And the NICE sugar study is a case in point. You know, despite patients being in an intensive care environment with one-to-one nursing, hourly blood samples being measured, hypoglycemia still occurred. And it's because, you know, between 2 1-hour finger pricks, you can quite easily dip into the hypoglycemic range. So I could see a future again whereby we will be using continuous glucose monitors as the standard of care in terms of monitoring people with type 1 diabetes in hospital, and indeed people with type 2 and stress hyperglycemia. You could see it across all of it. Now, obviously, the financial implication of that is not insubstantial, but if you factor in the morbidity and the mortality that we've discussed of poorly controlled diabetes in hospital, then...
And I'm sure there's evidence about it lengthening stay as well.
Yes, so, absolutely. Yes, yeah, absolutely right. So, you know, I can see continuous glucose monitoring coming in. And then if you do that, then it's a small step to say, well, okay, instead of having variable rate insulin infusion systems as we have at the moment, let's just put on an insulin pump device or some device that, again, is talking to the continuous glucose monitor. And if you do that, then you can aim for true normal glycemia in hospital. You can aim for a blood glucose target of 5 to 6 because these integrated closed loop systems will abolish the risk of hypoglycemia. So I will be long retired, I suspect, before that absolutely comes to pass. But to my mind, that is inevitable, that is the way that diabetes will be managed in an inpatient setting in the future.
It's quite exciting, really, isn't it?
It's very exciting. I have to say the technological advances that have occurred with insulin delivery for type 1 diabetes over the last 5 years have been seismic. Yeah. And these are life-enhancing, life-transforming advances. They actually offer the prospect of a technological cure for type 1 diabetes.
Yeah.
One of the things that I think will be particularly interesting is that at the moment, pump technologies tend to be given to people who come from higher socioeconomic classes, and they tend to be given to people who've actually got pretty good glycemic control. The sort of person who would never get a pump at the moment is the person who comes into the acute receiving unit every 6 weeks with DKA, the so-called brittle diabetes. Now, again, you could imagine a situation that actually that sort of person might be, you know, the reason they don't get a pump now is because if you're on pump therapy at the moment, you have to be absolutely on it in terms of giving your bolus insulin doses, monitoring your sugar levels. And of course, unfortunately, the sort of person that's coming into hospital all the time with DKA, they're not doing that.
Yeah.
And so that's why a pump is actually a dangerous thing for them to have at the moment. However, you can think in the future that giving people a closed loop system, that actually it's almost like a plug and play. You just put it on and you can forget about it. That I would like to think will reduce the socioeconomic disadvantage that there currently is for people with type 1 diabetes around access to technologies, but also, you know, reduce the frequency, the prevalence of these terrible situations that you know we see from time to time of people coming into hospital in severe DKA.
I think also there's a thing for the inpatient, you know, just going back to the stress response, uncontrolled diabetic or hyperglycemia. You know, there is a risk, like you mentioned, we parcel them up and package them on to different units. Actually, this gives continuity, well, you know, and there is a variability in the experience of units. We're very fortunate here in the West in that we have a lot of diabetologists and we have an in-reach diabetes service. But actually, you can see how this can empower you to provide that standard of care.
Absolutely.
And you know, speaking as an acute medic, you know, understanding that that's an opportunity that takes takes away that risk for the patient. I think there is a perceived benefit for them to have that standardization. And a technological advancement is always exciting.
Exactly. Absolutely. No, it is very, very exciting. One of my friends, a gastroenterologist in Glasgow, I'll name check, he's called Robert Bolton Jones, very, very good friend of mine, and they had a grand round at the Queen Elizabeth Hospital about 18 months ago on diabetes technologies, and Robert contacted me afterwards and said, gosh, when did diabetes get so interesting?
I don't think there has been a specialty with this much change, like you say, even from Dagami. When you look back to 1995 and actually, you think what's happened. It's been fast-paced.
It has been. Well, in terms of the technology, you're right. I mean, I think obviously in other specialities there have been therapeutic advances. You think of biologic therapies and things, but I think in terms of the technological solution, I think diabetes is certainly in the vanguard in that regard.
Yeah. And so just to come back to the sort of the hyperglycemic patients, so we haven't got these closed loop systems at the moment. No. Hopefully they will come. So keeping in mind the 6 to 12. And then in terms of, say you're putting somebody that's, I think I'd like to talk a little bit more about the COVID specific thing. We've talked about that in our last podcast, and you alluded to the ACE receptor and the impacts, but it does seem to behave differently in the acute, in the ITU setting with a lot of our patients. And I just wondered if you could talk about that a little bit more.
Yeah, so I think COVID is a very interesting infection in very, very many ways. I mean, I suspect the podcast that I did just over 12 months ago must be now horribly out of date, because obviously the field has moved on so substantially. But yes, there is no doubt that COVID does pretty bad things to your blood sugar levels, and I suspect it is combination. Well, time will tell. We don't really know the full answers as I speak now, but I think there's no doubt that there is a huge stress response to COVID. Just the severity of the illness, all those inflammatory mediators, all those stress hormones are causing extreme insulin resistance and are making a very major contribution to the very severe hyperglycemia that we see, that requires bucket loads of insulin to have any sort of impact on sugar levels. So I'm sure that the bulk of the impact of COVID on blood glucose is related to that level of severe insulin resistance that we're seeing as a consequence of the acute illness. But as I say, there is this suggestion that COVID may also directly impair the ability of the pancreas to produce endogenous insulin through the ACE receptor and through the ability of the infection effectively to get into the beta cells. And in fact, some centres in England are reporting an increased incidence of type 1 diabetes in paediatric populations over the last 12 months. Now, that's not been categorically linked to COVID, and that needs a major caveat on it. But again, it's just an interesting observation that has been seen.
It's an excellent research question.
Oh, totally. Yeah. There's no question about it.
So just to understand it, not only does it increase the insulin resistance due to the acute severity of illness, there is also a direct pancreatic response as well. So it's almost like a double whammy.
It's a double hit. That's what we believe. I think there's still a lot of work to be done on the pancreatic infection element. So I don't want to overplay that.
No.
But yes, in theory, it may be a double whammy that we're seeing. But I think that the severe insulin resistance must be a consequence of the acute severe counter-regulatory hormone and inflammatory response. I'm sure that's what it must be.
And we've certainly started to see people coming through, with who are now out of that intensive care period home, but they have quite significant sequelae of the severity of their infections. And you may not have the data yet, but are you starting to see an increase in those people suffering with either insulin resistance or diabetes full
So you're right. We don't really have the data on that at the moment. I think this is going to emerge in the next 6 to 12 months of, are we actually seeing effectively, because what you would imagine with, if it is truly this double whammy, that yes, the severe insulin resistance will resolve.
Yes.
As you get over the acute illness, that all melts away. The key question is then, well, are people being left though with diabetes still at the end of it? And that, if they are, that may be a consequence of the pancreatic infection. And that's what we need more data to know if that actually does come to pass. Are we seeing more cases of established diabetes in the aftermath of a COVID infection? That will be very interesting to see.
Well, watch this space. I hope we can come back and talk to you in another 6-12 months time. And because our first podcast left us with a lot of questions, and I think, it is an exciting time, although a very troubling time, with the pandemic, but it's been really interesting to see the evolution, the integration of research along with, and I think it has been a real celebration of that interface between acute care work and research.
Yes,
this has been
that's
going on.
Absolutely right. Well, it's interesting. One of my other roles is I'm one of the editors of Davidson's textbook of medicine. And we're just putting the final touches to the 24th edition, and the whole writing process takes about 18 months to 2 years. But the infection chapter came in at the end of the summer, and of course there's a whole section on COVID. But we realised at our editors meeting the other night that actually that COVID section is going to have to be completely revised now, because just in the last 6 months, the information, the data that we have has, it has moved on so dramatically. Yeah. So yeah, you're absolutely right. It's been a triumph in so many ways of that integration of primary basic research and clinical experience and research.
And I think the sharing between the communities, when it had hit Italy, the very fact that the RCPE were having the Italian specialists coming on and talking, I think it's been a real point of sharing and of learning, which has also been a real privilege to be part of. So I've enjoyed that. And everyone's become an armchair epidemiologist. Well, Prof, thank you very much for taking the time to do this podcast today. I've really enjoyed it and learnt lots, and it's changed a lot of actually how I will approach the acutely hyperglycemic patients. So thank you very much.
Not at all indeed, Rachel. My absolute pleasure.